So yeah, we do record these sessions.
Meeting is being recorded.
Yeah, that way we can share them with folks who weren't able to join. As we go through, and I'll say a bit more, we're going to have some great presentations today. We'll have opportunities for questions and discussions. So please, as we go, feel free to put questions in the chat and we will just keep collating and answer them as we can. If anyone ever has a question they aren't comfortable saying with their name or out loud, like feel free to, you can send a direct message to me or to one of the wisdom study people who are labeled like that, and we can make sure we ask your question too. So glad to have you all here for today. Should we get started? We're a few minutes past the hour.
Yeah.
Oh, all right. Do you want to move the slides forward, Allison? So welcome. For folks who maybe haven't been here before, this is our monthly wisdom study community forum. Our mission, the reason we have these is we're trying to move together towards equity and better outcomes in breast cancer for everyone. That's sort of the goal of our research in general, but of these forums specifically. And we do that because we know that breast cancer isn't just one disease. It can be, some are aggressive, some are more easily treated. Who gets breast cancer and when and why can really vary. And we're just sort of in some ways beginning to advance our understanding of who gets breast cancer, what can be done, are there ways to prevent or to reduce our risk, and how do we know the best ways to treat everyone? That's why we're here today. So our topic for today, we've been doing this sort of mini series of thinking about breast cancer across the lifespan at different ages. And today we're going to be thinking about menopause and breast cancer, getting older, going through hormonal changes, and what that looks like. So we have a great panel of folks today who are going to speak. We'll let everyone introduce themselves as they come up, but we're going to start with Dr. Andrea Lacroix in just a minute. I think we have a couple other housekeeping slides before we get to that. Am I right about that, Allison? We have a couple more things we want to review. Yes. So as I said, we really want this to be a discussion. We have some folks who are giving presentations talking about research and clinical expertise that they have, as well as expertise, lived experience as a patient. But please send us your questions in the chat or raise your hand when we get to the discussion portion, speak up. We really want to hear what you all know, what questions you have, and what we should be thinking about. But while you're not speaking, if you can go ahead and click the mute button to make sure everyone can hear what's going on, we don't get background noise. And as we said, we will be recording so that others can view this as well. At the end, we'll have a little survey just to learn more about what you want, feedback on this, and what folks want to know for future sessions. And yeah, just a little bit about what we've discussed previously. So we've talked about breast cancer in specific communities, as we talked about it over different age groups. We've talked about clinical trial participation. And this month is on breast cancer and menopause, and we'll see what you all think. Please let us know what other topics you want us to make sure we're covering in the future. So without further ado, I'm going to turn it over to Dr. Andrea Lacroix, who is going to, I'm hoping will first introduce yourself and then tell us a little bit about your research and My Menoplan.
Can you hear me okay?
Yes, we can. Welcome.
Thank you, Jen. And I just want to say hi to everyone, how exciting it is to be with you and to have so many people from across the whole United States. Everything I'm telling you about today, I hope you'll share with your friends in midlife who are having menopause symptoms, because the information we'll present today pertains to everyone. I'm not sure what these stray lines are on this slide.
I think someone did an annotation. I'm trying to figure out how to
accidentally wrote on it. Yes.
I'm trying to undo it.
Features.
Let's see. We'll keep working on it as you're talking.
Okay. So I've been part of a network of researchers from across the country at different academic centers called the Miss Flash Network, funded by the National Institute on Aging to develop new strategies and test existing strategies for management of menopause symptoms. And our work has been funded for about 15 years and just wrapped up in March of this year. So we've been busy getting the word out about all the things that we've learned. And one of the resources that we developed at the end of this was a website and digital platform called My Menoplan. Let's go to the next slide. Oh, thank you. Nice erasure. I assume you can advance the slides because I can't, right?
I can. Hold on. I just was erasing, so now I'm trying to get my pointer back. There we go. All right,
Okay.
there we go.
So this slide is a slide that I put together from all of the news stories that came out during the pandemic about women suffering at home with menopause symptoms, suddenly at home, taking care of children, holding down the house, and also trying to work, and really, recognizing that menopause is this sort of hidden condition that people don't like to talk about, but it's universal, it's ubiquitous, it happens to all of us, it's natural. And why do we speak so little about it, and why don't we share what we know? It turns out there's been a lot of science about effective treatments for menopause. There are advances in equity in terms of inclusion of minority women in these studies. And we very much have contributed to this and want to make sure that all of you get to benefit from the investment that's been made by the National Institutes of Health in this topic to help women. So let's go to the next slide. I also was a Women's Health Initiative investigator, and this is the Women's Health Initiative WHI estrogen plus progestin trial. We actually did 2 estrogen trials, one on estrogen plus progestin for women with a uterus and one on estrogen alone for women without a uterus. And we published findings in July of 2002 that surprisingly told us, whereas we thought estrogen plus progestin was a good medicine for prevention, in addition to management of menopause symptoms, it turned out that there were many risks that we were able to quantify in the WHI trial that were associated with increased risk. So a 29% increased risk of heart disease, a 41% increased risk of stroke, over a doubling in the increased risk of blood clots in the lungs, and a 26% increase in breast cancer for estrogen plus progestin. On the decreased risk side, we saw fewer hip fractures and fewer colorectal cancers. But when we think about a drug that we thought would be good for prevention, it's absolutely unacceptable that a drug would be given to women for prevention that causes heart disease, stroke, blood clots in the lungs, and breast cancer. So that's what we learned from WHI. And because this was estrogen therapy was the backbone of menopause treatment, the National Institute on Aging funded the Miss Flash Network to make progress on alternative ways to manage menopause symptoms. So we can go to the next slide. And this is a picture of Bernadine Healy from my home state of Ohio State. And the Women's Health Initiative was started by Dr. Healy. And this is a quote from her: women have to understand that their health and well-being is affected and determined by personal choices. That includes personal medical choices. There's not one medication or one practice that suits all. And this came after the publication of the Women's Health Initiative findings. I think we had all hoped that this medicine would be broadly beneficial. And then when it wasn't, we realized that we realized that every person is an individual and has to make their own choices. And the more evidence we have, the more informed those choices can be. So let's go to the next slide. So the aims of the Miss Flash trials, this was our network. Well, the aim of the My Menoplan project was to develop and pilot test a comprehensive state-of-the-art multimedia national digital resource, something that all of you could have that would help you to understand your options for managing menopause symptoms, and that this resource would facilitate informed decision-making for managing those symptoms. So in the next slide, I wanted to say that this is an evidence-based resource that's based on published data from our own network and all the other research of a high caliber that's been done. These are all doctors from across the country who participated in evaluating the evidence and feeding it into the information that you'll get on the website. So this is not done with any drug company funding whatsoever. It was meant to be an academic-based, trustworthy, NIH-funded resource that people could depend on for accurate information. And we did talk to women before we developed the website and allowed them to inform how we envisioned it. They thought it would be unique and innovative for a website to be developed for women by women. And they helped us to organize content around 3 motives for entering the site. One is understanding what menopause is and how long it lasts and so forth. What are the treatments? What are the symptoms that women might experience during the menopause transition, inclusive of symptoms that are just common in midlife that tend to arise when we get to around the age of 50, and then what treatments are there to alleviate these symptoms, and what do they work for, and what are their risks? And we also checked back with women with beta versions of the website and got their input on the visualizations in there, how to navigate, and how the content read. So very much involve the women in the development of this resource. And the content includes a question and answer, myths about menopause, strategies for talking with your doctor, special populations, especially women with a history of breast cancer, and even transgender or non-binary women, because there's almost nothing out there for them. We wanted to create credibility and build trust through including women's real voices. So we have women speaking about their own menopause transitions, and we have some content showing you the members of our team and who we are and our expertise. As well, every single paper that we've published in the Miss Flash Network can be accessed through this website. You can actually pull up the papers and read them or print them out or take them to your doctor. And so it's a complete compendium of our publications. And I think that I've already covered this content, so we can keep going. This just shows you the evidence that we relied upon, meta-analyses, which means analyses of all the evidence combined. And we have information in the website about how we sort of evaluated the research quality. There's times when you want to know about whether something works or not, and there's no research to support the effectiveness of certain treatments one way or the other, so we let you know about that. And then we also wanted to build in information about the effect size. So I'm hoping that we're getting to the guided tour of the website, because I really want to show you that. There's also, let's go back though. There's this My Menoplan tool in the website where you can actually, imagine that you're shopping on Amazon and you pick out 3 different, toasters and you want to compare them side by side. We let you do that with menopause treatments in the My Menoplan tool. If you want to know about symptoms, you can choose symptoms that you have, and we'll let you know which treatments work for those symptoms and compare them side by side. There's also tools in the website that help you evaluate if you're in menopause, what stage of menopause that you're in, and how to add factors such as whether you're using an IUD or birth control. And then there are validated screening instruments if you want to measure your own levels of anxiety, depression, and sleep. And you can experiment on yourself with some of the treatments and see by using these symptom questionnaires whether you're improving or not. And then there's printable diaries, so you can keep track of your hot flashes and night sweats, how well you slept, how many hours you slept, and whether or not you had bladder leaks. So these are all resources within the website. And we worked with a web designer who helped us hopefully create a welcoming look and feel with lots of inclusive videos, women's stories, important messages from Dr. Reed, the OBGYN on the team, and a tour of the website right inside there. So I think we should be up to the tour. And so can you click on that YouTube video and we'll all just take a tour of the website together?
Yes, give me 1 second. I'm going to stop sharing and then share with sound real quick. Let's see.
I'm glad you're doing that instead of me. I always fumble at this point. Sometimes when you click, it goes right to it and comes back, and sometimes it doesn't, depending on the platform.
Okay.
Thank you so much.
If you're going back to school,
We're seeing a different screen, Allison.
Run it through Grammarly to quickly check for spelling, punctuation,
your
and
email.
grammar mistakes. Look at the marks from my last 2 essays and the feedback from the examiner. I have used Grammarly since secondary school to
See,
check.
again, I'm glad I'm not doing this because
Grammarly is a digital writing assistant that improves your writing.
Oh my
and
gosh.
Just
saves your
as we're getting that going. So just for folks, if you have questions, if you want to put questions in the chat, we're going to try to look at this website, which has some resources and tools for thinking about how to manage menopause. And then we'll move in a little bit to thinking more about menopause and breast cancer and all these options for treating symptoms in breast cancer. So just for folks, so folks know where we are.
New to learn about the menopause transition and postmenopause, or just want to know more, check out About Menopause. Look at the Q&A and see how we bust some common myths. You can use a tool to see what stage you're at. Get tips for talking with your healthcare provider. There are special sections for women with breast cancer and transgender men, plus a bonus section with science-based advice about staying healthy in midlife. Maybe you are wondering about your symptoms. What's common? What can you do about them? When should you see a doctor? You can learn about each symptom on its own page. Learn what is happening in your body, what to expect, and how to find relief. Our toolbox can help you assess how bad some of your symptoms are, or get you started tracking with a downloadable diary. If you have questions about coping strategies and treatments, check out our treatment pages. Learn what science says about whether a particular approach has been shown to help other women or not. If the science is uncertain, we'll let you know that too by marking it may help. Learn about the risks and the side effects. If you want to try a treatment or coping strategy, we'll give you tips to get started. You can put it all together by creating your Menoplan. Just pick your priority symptoms and find the treatments that help or may help. You can narrow your treatment search using filters too. Armed with your plan, you can talk with your healthcare provider if needed. Share information and start trying treatments to see what works for you. Check out our videos for tips on how to decide what to try and how to try them. Watch and read stories from women talking about their perimenopause and menopause experiences. Lastly, you can learn more about who we are, the scientific approach to the information on this website, and get links to our publications. We're so pleased to share these resources with you and hope you find them helpful.
And that Taylor Swift is not part of the website. Just want you to know that is separate. So I hope
little
that sort of whets
pre-menopause.
your appetite to go visit the website and explore. It's just mymenoplan.org. Everyone can go there. It's fully open. You don't have to give.
Introduce Jason King.
Oh, you got to shut off YouTube. I always have that problem too. So I just want to say you don't have to give any personal information to get in here. You don't need a password. You don't need to give up anything. It's just there for you to get into and explore. And if you have questions, I'm always there for you as well, my team members and the My Menoplan team. So I just wanted to say, is there anything after this?
No,
we did do a,
oh,
is this, I did want to tell you that we did a randomized controlled trial of this website versus other reputable websites on the menopause transition And the controls were the North American Menopause Society website, the National Institute on Aging Menopause webpage, and the Office of Women's Health. These, you got to choose which of these you went to, or you could go to any other menopause website that you found on the web. And you can see here which sites were visited by women in the control group of this trial. And then if we go to the next slide, just very quickly, it looks like they took out the findings, but the My Menoplan website did do better. It resulted in greater knowledge, decisional progress, and intentions to try a new treatment than the comparison websites. The website evaluations for My Menoplan were more positive than the comparator websites, although they're all reputable, and the other websites were also highly regarded. And our results were likely conservative because the comparators were not commercial websites pushing one thing or another. We weren't really in a position, for example, to send you to WebMD for various reasons, but and there are other websites that are pushing one treatment or another, but these were against reputable websites. So we feel good about this, and we're disseminating it widely and getting ready to publish a paper on this randomized controlled trial. And I welcome your questions today about menopause and treatments and that sort of thing.
You know, Andrea, I was going to say that, you know, just one of the things that I think are really very common, and I think sometimes there's two things about the medications that we often use for the treatment of breast cancer, whether it's tamoxifen or an aromatase inhibitor. These are drugs that either block the estrogen receptor or just lower the amount of estrogen that you have in your body. But Patty Gans and others have shown that a lot of times the side effects that people think are associated with those drugs are often primarily driven by menopause symptoms. And it's also known that the closer you are to menopause, the more likely you are to have symptoms, you know, from these other drugs. And, you know, sometimes it's a real struggle for people. And I think this is one of the reasons why it's very important that you have physicians that you can talk to and sort of weigh the kind of challenges that you might have and how you're feeling, because it's not a right or a wrong. There's no perfect answer. And a lot of times there's trade-offs, and you have to sort of see how are you feeling? And, you know, it's not that there's a case where there's absolutely, you can never use estrogen. You know, I think pretty much you don't ever want to use progesterone, but, you know, even Rowan Jablowski and others have shown that if you're on estrogen alone, you know, your outcomes aren't worse. So there can be reasons for that. There are medications that are out there that combine a little bit of estrogen with like a fourth generation SERD, like SERM, like Duave. So there, you know, everything, just like in your breast cancer treatment, there isn't a perfect answer because everyone's a little different, and every decision is a trade-off, and you have to weigh those choices.
That's exactly right. I think that's so important, Lauren. And that's something I heard from Dr. Lacroix as well, is this idea, every person's an individual. We all need to be able to make informed choices. And I think what's great about having something like this is there's a resource for it. I think for a long time, women just sort of suffered in silence and didn't talk about it. We didn't talk about how long menopause lasted. We didn't talk about all the symptoms. And so what are the ways in which we can really be aware of what options we have and surface the questions that people go through? We're starting to get a few questions in the chat. I actually, while we look at those, I wanted to turn to Rita, who's a member of our team and who's going to speak a little bit, I think, to some of the questions that a lot of patients are facing, a lot of human being people are facing as they're getting to the menopause era. So Rita, do you want to share with us a little bit of your story and how you're approaching some of these decisions, or how you have approached these decisions?
Sure. Thanks, Jen. Yeah, so my name is Rita Rue. I'm a wisdom participant and actually also work on wisdom with all the esteemed panelists that are on today. And this topic has been of importance to me for a variety of reasons. For some background, I am a cancer survivor. I have cancer in my family, my dad, my nephew, my aunt, my uncles, and I was diagnosed with and treated for metastatic thyroid cancer 5 years ago and have been cancer free. So cancer is something I worry about. And part of the reason I'm working on wisdom is because of my interest in helping people and learning about cancer. I've also struggled with the decision about whether to take hormones for perimenopause, menopause symptoms, and have had periods of time where I've taken hormones, where I've not taken hormones, primarily oral birth control, and definitely seemed to help me. And a lot of my friends are struggling with this decision. And unfortunately, 2 months ago, I was diagnosed with ADH, precancer, borderline DCIS, which is ductal carcinoma in situ. It's stage 0 cancer in my right breast. And I have to admit, I actually talked to Jen before this just to kind of download on how I was feeling. I have to admit, I have some regrets that I didn't stop taking hormones sooner. And so I only bring that up because, it's such a difficult trade-off. As Laura mentioned, there seem like significant lifestyle benefits to taking hormones. Obviously there's a whole birth control issue, and it's just it's a difficult topic. And I'm assuming people out there are wondering, how to make the decision on how to weigh these personal risks for blood clots, breast cancer, heart disease, and who we should talk to, which types of physician or people should we talk to help us weigh these risks.
Thanks so much for sharing that, Rita. And what I said to Rita when she mentioned this to me is like, it makes me so sad that you feel that sort of personal regret, although I think many of us do that too, and everyone's entitled to their feelings. But I think with breast cancer, we'll never know. You never know what causes anything for sure. We can't pinpoint it. And I think you're right. Like there's just so many trade-offs. Like the lifestyle stuff, I feel like we easily dismiss it. It's really huge. Being able to sleep and feel comfortable and go about your day. These feel like impossible decisions, I think, to make, right?
Well, I think one of the things though about that is I think what we need to do is start thinking about things that, I think, that are safe, that, the trade-off when combined hormone replacement was put together, and Tessia can attest to this too, right? So the idea was, you could get buildup of the uterine lining if you give estrogen unopposed. So the right trade. So let's give progesterone, and progesterone will prevent that. Not that people love having their periods or, all of that all the time, but that was the trade-off. Probably not in retrospect, totally in retrospect, not the best choice, because the kinds of cancers that you get from buildup of the uterine lining are usually fairly benign, and some of the cancers you get from the combined hormone replacement is worse. So that, can be quite significant. So for breast cancer. So I think we have to think about what are safer ways to do this. Drugs like Duvet, are they safe? There's a clinical trial that Carol Fabian is running. We actually are participating in it too, for women who have a lot of menopausal symptoms and at high risk or have atypia. It's designed exactly for that. Some of the preliminary data is pretty good. And, why not, try and find the drugs that make people feel better? Looking, even when you're taking drugs for treatment, how fantastic that we've been able to now get drugs dropped down. It turns out that 5 milligrams or baby tam is a whole lot more tolerable than 20 milligrams of tamoxifen. And at least for DCIS, and at least for using the endpoint of density change, it looks like that dose is just fine. And a lot of these drug doses are higher than they've needed to be. So we have to do a whole lot more work to make things more tolerable. That's, I think, and as you know, I talked to the people who make lasofoxifene, it's very sad. There's a lot of things that drive what can be developed and what can't. And it has nothing to do with how they should be developed. But there are drugs that are more tolerable. And part of this is getting people to want to develop them for this kind of use and to run these kinds of trials. And that's why people like Carol Fabian, who's she has really killed herself to get this trial up. I think it's such an important trial for women, because if it actually turns out to be safe and lowers risk, they've never put someone on this drug whose menopausal symptoms didn't go away. and Carol too. I mean, can you imagine having a drug that actually reduces your risk and, also.
And Duobay, just to be totally transparent, is a combination of estrogen plus a SERM. Is that correct?
That's right. So it's it's somewhere between a SERM and a SERM, like these selective estrogen receptor
Yeah.
modifiers or degraders. And it turns out, I mean, it's not like estrogen's all bad. I mean, we know that progesterone is the culprit here. So it's trying to find these and getting people to invest in these trials. Like there's data on low dose testosterone and an aromatase inhibitor. There's like all kinds of things that are out there that should be tested. We have to push people in the field and the people who fund it to pay attention to these things, because there may be things that are really quite tolerable that make people feel better and reduce their risk. We shouldn't assume that it's not possible. I think sometimes people think that if you have to suffer to get treated, or and that's not necessarily true.
Well, I mean, we tested some drugs. I do want the audience to know, that the era of big trials kind of ended when WHI was published, because the drug company makers got very concerned about big trials because they really do show the risks and benefits of a medicine. And you have to do a very large trial to find out if a medicine causes cancer. You can't do a little tiny trial. So, being aware of how important the research is crucial. When I say big trial, the WHI hormone therapy trials, the estrogen plus progestin trial had 16,000 plus women in it, and the estrogen alone trial had 10,000 plus women in it. So that's the level of bigness that we're talking about. Wisdom's even bigger than that, because we need a lot of women in Wisdom to show basically that less screening is not dangerous and might have more benefits and less harm. I do want to say, though, if you have, for the question, are there non-pharmaceutical natural treatments for menopause symptoms, please check out on the website. If your predominant symptom is trouble sleeping, which is incredibly common in midlife, there's really good evidence that cognitive behavioral therapy for insomnia is way better than any medicine, including hormone therapy, like 3 or 4 times better. That is something that you can access. There's also other therapy.
What is it that's better for insomnia?
Cognitive behavioral therapy for insomnia, which is not the same as sleep hygiene. It's actually CBTI, and you can get this, and the women improved way better than any sleeping pill, any hormone therapy, any other pill that they could take in that trial. And there are other natural remedies in the website, like acupuncture and massage and hypnosis. And it's worth taking a look at the evidence for those treatments, because there's a fair amount of evidence for things that we didn't study in Miss Flash, like hypnosis, that it might be beneficial. So we have all kinds of information in there about all those things. What else would I say about this topic is that research in women's health is super important and underfunded, and we need to do more of it so that we're in a stronger position. Also, that women are an incredibly large market for drug companies, meaning there's a lot of us. We all go through menopause. And so when they look at developing a menopause treatment to make money, they're not necessarily thinking holistically about our wellness in the drug company sphere. And that's why we need NIH to do these trials as well.
I think that's so important, right? We need to be able to, as you said, we need to look outside, both make the drugs better, make sure they're having fewer side effects, fewer risks with more benefit, but also make sure we're really understanding, what does exercise do? Someone had a question about that. Massage, acupuncture, lifestyle changes. We need to understand the whole picture. It's so important. But something else, that I was hearing, I feel like, both Dr. Esterman and Dr. Lacroix were talking about different types of drugs and the mechanisms and what they do. And, a lot of detail we can't get into here that, like, I definitely fully don't understand. But I think for me, what I think about is, what do I need to be able to ask my doctor? What are the questions I need to bring up? How do I move forward? And I'm hoping we can transition to Dr. Tessia McKenzie, who's a breast cancer fellow, breast cancer surgical fellow here at UCSF. I'm hoping you'll introduce yourself, who can talk with us a little bit more about what we know about breast cancer and menopause. And I'm hoping we can then start getting to the, what should I bring to my doctor? What do I need to understand to make decisions for me?
Absolutely. Hello, everyone. Thank you, Jen. My name is Dr. Tessia McKenzie, and like she said, I am a breast surgery fellow. I actually work very closely with Dr. Resterman and the rest of the Breast Cancer Center here at UCSF. I did complete my residency in OBGYN, so menopause is a topic I'm pretty familiar with, so I'm really excited to be invited to talk to today. So why don't we get started? So some quick facts about breast cancer. You know, it is the most frequently diagnosed cancer in the United States, making up about 29% of all cancers and 16% of cancer-related deaths. It's quoted that 1 in 8 women will develop breast cancer in their lifetime, and half of that risk really occurs after the age of 60. Go to the next slide. So what are some risk factors for developing breast cancer? I'm not going to, read this whole list, but, definitely family history is one major risk factor, as well if you have a family history of not only breast cancer, but ovarian cancer as well. And some of the hereditary breast and ovarian cancer related also cancer, such as prostate cancer, that can increase your risk. If you have a mutation in some of those genes that increase your risk, you may have heard of BRCA or CHEK2 mutations that can increase your risk of developing breast cancer, as well as early menarche and later onset of menopause. We'll go into that a little bit later, but it has to deal with the amount of estrogen that your body is exposed to, and that longer period of time does increase your risk for breast cancer. But as well as, increasing age, BMI, your alcohol and intake, as well as smoking will increase those risks as well. Next slide, please. So, I just said that, increasing age is a risk for breast cancer. And this is just a chart that I took from the NIH website. And you can see that the average age of diagnosis of breast cancer is 63 years old. But if you look between that 55 to 74 year old range, that's when most of those new cancer diagnoses are occurring. But if you think about what's also happening between that 50 to 60-year-old range, we can move to that next slide, is menopause. It's also happening at that same time. So now we'll just transition into talking a little bit more about menopause as well. So what is it? So it's defined as actually 1 year without having a period. That's when you start menopause. Sometimes those symptoms of the hot flashes, the night sweats, the mood swings, those are, some menopausal symptoms, and that can actually be started before you actually go into menopause. It can be started earlier, and that's called either the perimenopausal or the menopausal transition period. But when you are in menopause, that is when you haven't had a period in 1 year. That usually happens on average at 51 years old, and that's going to be due to loss of ovarian function and then your decrease in estrogen. Go to that next slide. So a little bit more about that happens. So estrogen, it's a hormone. It's primarily made in the ovaries, and that is what's really controlling. It's one of the main hormones controlling the menstrual cycle. So during that menopausal period, you can see those estrogen levels are decreasing, and because of that decrease, your periods start to become irregular, and then eventually that estrogen level is so low that you're no longer having your period. Your body is trying to kind of adjust to these new levels. And so it's really going berserk almost, and you're feeling those symptoms. And that's really with those hot flashes, vaginal dryness, all as a result of that decrease in estrogen. But, I had said earlier, that later onset of menopause and then earlier onset of menarche can increase your risk for breast cancer. That's just because now you have longer exposures to estrogen if you're moving that menopausal time to a little bit later. Next slide. So some of the breast changes that happen during menopause, so your breasts become a little bit less, it becomes less dense, and that breast tissue is really replaced by more fatty tissue. The ducts and the glands that are in the breast, they really kind of atrophy and they collapse. And if you can see in this image, with the most dense breast being on the right side of the image versus a more fatty breast being on the left, you can imagine it just transitioning from right to left. Okay, next slide. And there's the arrow that shows that. This is just another image of some symptoms of menopause that you can experience. Some people experience one of them, all of them, or none of them. But you know, we can't say who is going to experience what, but it's really important to kind of know that some of these things are natural and can happen. Okay, next slide. So when it comes to treatment, like I said, we don't know who is going to have the most severe symptoms, how long they're really going to last for you, and that all varies. And based on the WHI, study, even with those results, hormone replacement therapy is still considered one of the most effective ways for combating those menopausal symptoms. There are other options that are out there, but they were seen as less effective, but they do work. It's not saying that it's not going to work for you, but some of those things, the antidepressants, SSRIs, SNRIs, clonidine, gabapentin, some herbal remedies, they are out there and they can work. But like I said, hormone replacement therapy is still seen as one of the most effective. So some of the risks and benefits, Dr. Lacroix is probably very familiar with these images here, but I just put them to just say that this was talking about what the increased risk that they found, and it's correlating with that scale that was at the beginning of the presentation. And that increase was if the lighter line are those who are taking the combination hormone replacement therapy, with the dark compared to the darker line who were not taking it. You can see that those who were taking the combination hormone replacement therapy had increased risk of breast cancer, of heart disease, stroke, and of pulmonary embolism. And then the next slide. And those who had decreased risk would have been of the colorectal cancer and of hip fracture. So this was just an image that I included there. Okay, next slide. So what we really want to talk about is, who do you talk to and how do we rate those risks and benefits? I think that all women no matter their age, should really be talking to their OBGYN, because they are the specialists really who deal with menopausal symptoms on a daily basis. And they would really be able to help you individualize your care and kind of associate and really take the different risk factors that you have and come up with a plan. So what's really important also for patients, and I advise them, is that you need to really know your history, because for us to really help you, it would help if you tell us if you have a family history of breast cancer, of ovarian cancer, if you're able to have access to that. If you're able to be honest with us as well and say, do you smoke? Do you drink alcohol? And that will help us to come up with a plan that's best for you and find out what that risk is for you. Now, I said, I wish we had a crystal ball that could tell us who would be taking hormone therapy and who will have this, have these adverse events happen, or who will develop breast cancer, but we don't. I'm sure people have heard out there of people who are very unhealthy and do everything they're not supposed to do, and they're completely fine, versus someone who's, doing everything they're supposed to do, and then they have this unfortunate diagnosis of breast cancer. And I wish we could say that, but it's really, what we want to do is really help you to weigh those risks and talk about them, and to hopefully come up with a plan that's best for you. But again, these are risks and they're not guaranteed. There's still, a lot of studies that need to be done on both hormone replacement therapy. There's a lot of changes that has happened since, these results have been published. So different practices, different things are coming out. And Dr. Esserman had mentioned there are a lot of new drugs that are coming out that may be very helpful in treating these different symptoms, and while also taking into account those different risks. So, but talk to your doctors, your OBGYN, if you happen to be one of those survivors of breast cancer, and then you're also wanting to go into menopause, talk to your oncologist. That's okay if they have any information to give you, your breast surgeon as well. So we're here for you, really. But I wanted to, really leave time to answer questions. So if anyone wanted to ask any one of us.
That was a great overview. And thanks, Dr. McKenzie. I feel like you're such a great resource, having been trained as an OBGYN. So seeing these on sort of people planning, the planning stage, and then also now being a breast surgeon. So sort of seeing many sides of this equation, which I think is great. If folks have questions and want to put them in the chat or raise your hand, or, virtual hand or physical hand, please do. I'll start the ball rolling. I guess one question I have is, I'm curious when should someone start talking to their OBGYN about this? Do you wait until your symptoms start? Is there an age? Is that, when I should start thinking about what's my plan for menopause? When should I start thinking about it? Knowing that perimenopause can last like 10 years, right? I mean, it seems like the clock's ticking. When should I have this conversation?
I think the earlier, the better. I think it's never, I wouldn't say at 20 years old, but you're starting to think about it. And if you're starting to have questions, then ask them. I think it's never too early, because if you are aware of what you can expect, then it might even make that menopausal transition a little bit easier, because okay, this is something that's supposed to happen. My body's going through these changes. It is a natural kind of order of events. But this way you have that relationship, you've opened that dialogue with your physician, with your provider, and then you can really kind of track where you are in that menopause transition too. So I think if you're having questions, ask them.
So I do want to say something ornery about this. I don't have an OBGYN, and except for having my twins, I've never had them. They are systematically more likely to prescribe hormone therapy than other doctors for midlife symptoms. And they're also systematically, according to the research, more likely to view menopause as a, medicalized condition and less likely to view it as a natural process. So I just throw that out there. I'm sure that's not you, Tessia, but I know a lot of, I speak to a lot of OBGYNs who, they were the most resistant community to the WHI data. And so if you want to get a hormone therapy prescription, seeing an OBGYN will get you there faster than seeing any other kind of doctor. And I just throw that out there because you got to tell them if you want to know the holistic picture of this. You won't necessarily be told about other options when you go there.
And I think it is true that if you had a history of breast cancer, and depending on the type of breast cancer you've had, people are often concerned about giving any kind of hormone replacement, which is understandable and many times very appropriate. But I would also say that I've had patients who, suffer really, there are things that can happen. People of underlying depression can get really, very seriously affected when their hormones are out of balance. And, I think that's the same thing. If you just can't tolerate things, and you can look, there are really a lot of alternatives, and having this website, this resource, this is so fantastic. Andrea, congratulations for doing that. And I think it's really great to have people try things that don't work, but to remember that, this is, sometimes between the menopause symptoms and the medicines we give, people really get a lot of hot flashes, and some of these things really don't work. And, all the antidepressants at very low doses can take the edge off stuff. And sometimes if you just can't sleep, it can just make all the difference in the world. So there are lots of things to try. And I think it's never good in medicine people say, well, I want the answer and I said, well, there are no absolutes. Everything's a trade-off.
The other
Whether
thing
you're-
to highlight, Laura, in what you're saying is the magnitude of treatment effect. It's people assume that if you take hormone therapy, it gets rid of your symptoms. If you take like the dose tested in WHI, which is no longer the standard dose of hormone therapy, it's too high, right? It was too high a dose, and it caused all those problems like other diseases. If you take low dose hormone therapy, we have a trial on the MISFLASH that compared low dose hormone therapy to an SSRI, an SNRI, and placebo. There's very little difference at a low dose, and the amount of relief that you get is like around 1 hot flash a day. But it does make a difference to women to have the edge taken off. So I just want to emphasize what Laura said, that all you may need is to have the edge taken off these symptoms. I had lots of hot flashes because I was a WHI investigator. I never took any hormone therapy, and I'm still here. I made it through. There's nothing like some ice around your neck.
Yeah,
get through a bad day.
So over a decade. And,
Yeah.
I keep thinking to myself, gee, isn't it time for them to go away? But
They do keep coming. They do keep coming.
for something, it's funny because, I have a sister who's a radiologist, a brother who's a gynecologist, and then there's me. And then my mother took hormone replacement like forever. Anyway, it was, we always had very interesting conversations, and different thresholds. My sister's taken and I don't. It's just like, I think it's about what you, and she was a mammographer. So, it's about what you are exposed to,
And I think it's individual choice, but I also think it's important to remember that like these are choices that can be changed. You can take it and then decide not to take it. You can, and also I think Andrea, your point about which doctors are going to recommend it. You can ask lots of doctors. You can ask your OB/GYN and then go ask your Eastern medicine provider and then go ask your family. You can get many opinions, right? There's no definitive answer, I think is great. There's a hand raise and there's some questions in the chat. I'm going to go to the questions in the chat real quick that I think could be put together, which is around screening and risk prediction for breast cancer. So I noticed, how'd you think about screening in menopause? When should they be done? I think I find a little bit confusing. Breast cancer rates are going up, but also your breasts are getting less dense, which is good for breast cancer. So how should we think about screening? I don't know if somebody wants to take that one.
I think that's a Laura Esserman question. Like, should the fact of menopause affect when you start mammographic screening?
No, I mean, as I like to say, I think screening should depend on what your risk is.
Yeah.
Right.
Well,
and that's one of the great things about being in Wisdom, that we, it's like, if you have incredibly low risk of getting breast cancer and you have like horrible hot flashes, okay, then you've got lots of choices open to you. If you're a BRCA2 carrier, like I would not recommend that you take, endocrine therapy, and I would go through everything systematically on Andrea's website, and just, there's lots of things that I think that why we should know our risk. We should be able to make choices. There is no question that taking postmenopausal hormone replacement will increase your breast density. Interestingly, the antidepressant drugs don't do that. And we know that taking, some of the medications, certainly on MRI, they reduce some of the background, and and when you're young, tamoxifen can reduce your breast density. So these are things that actually, can help. And, everyone's not the same and everyone has different responses. But I think when you screen, how you screen, and what you do about it really should depend on what your risk is, that we can be smarter about it. And there shouldn't be one size fits all. I say it all the time. Everyone's not
questions. I totally agree that so there is an uncoupling. Like menopause doesn't mean, yes, it's true that most breast cancers are diagnosed between 45 and 65, over half of them. But that doesn't mean that you should start mammographic screening at a certain age. That's part of what we're testing in Wisdom, right? Is a risk-based strategy. A couple other questions that came up. What about exercise? Exercise, it doesn't improve hot flashes, but it improves so many other things.
Including your
In
risk of breast
public health, we recommend, and you don't, a big part of my research program is studying how hard you have to exercise and in aging women. And the answer is not very hard. Everything you do counts. And so we published some of the first papers showing that light physical activity and also just daily life movement, just the stuff that we women do all the time, taking care of other people, keeping the house up and so forth, gardening, all of that is good for your heart, good for your longevity, you know, all that kind of stuff. So it doesn't help with hot flashes, but I always like to say that it does get you used to sweating. And maybe that's half the battle, is just getting used to sweating.
Which is great. A couple of
The
just
other
rapid
question
fire
was-
questions. Well, we have a couple questions. I want to get to a couple questions in the chat. I was just going to
I had
know.
a question too for Tessia.
So just a quick, this is gonna be a quick yes or no, which is sort of, does Wisdom take into account hormone replacement therapy in the risk assessment model? Laura, do you know, is Wisdom currently taking into account?
We take into account
Yes.
whether you take postmenopausal hormone replacement. We take into account whether you've taken things to reduce your risk as well.
Great. And then the other thing I would just note that I was hearing, they were mentioning breast density seems to be a big key. So that's just a reminder to everybody to know your breast density, and you can see it over time. And at least in California, it has to be on the report you get from your mammogram saying that your mammogram came back without breast cancer findings. So that's a good thing to empower folks to know. Diane, you've had your hand up. Want to go to your question?
Yeah, just I'm wondering if the ups and down surges of the hormones at menopause have an impact on breast cancer. So do we know anything about the kind of, you know, very dynamic time of life for hormones and what's happening there? I was diagnosed for the first time with breast cancer during a very difficult perimenopause.
You know, people always want to think that some, you know, everyone thinks that it's either during fertility treatments or during menopause or whatever. I mean, I think it's because the problem is these are all really common conditions. Menopause is really common, and increasing fertility is really common. It's really hard to sort of figure out what those links are. Someone asked about contraindications for antidepressants and tamoxifen. So Paxil and tamoxifen, for example, should not be taken together, but any one of the, effects or any one of the antidepressants, at very low doses, at like 1/10 of the therapeutic dose, lower hot flashes. They just happen to note it in a clinical trial. So it's just one of those things you just have to know. I wanted to ask Tessia and maybe some of the other people, I'm just interested to know about the different attitudes about menopause treatments and race, is it, are people thinking about it differently in the African-American community than the Asian community, than the white woman community?
Yeah, so I know there's some studies out there that say that African Americans may be at increased risk for having more vasomotor symptoms versus maybe Asian women have it less. But
what kind of symptoms are those?
Vasomotor symptoms, meaning hot flashes, night sweats, those perimenopausal symptoms, right? That African Americans are more at risk for having that. I'm not aware currently. I can look into it if there are any other studies that are looking at treatment, individualized treatment for that. But just one thing that I did want to say is that, I'm sure, and I got a plug for my co-OBGYNs, is that I think if anybody came, especially using something that they saw from the My Meno plan, and they didn't want to start hormone replacement therapy, and they were looking for other types of treatments for their menopausal symptoms, I am, for the most part, you should be able to speak with your physician, and they'd be able to come up with a plan if they do suggest hormone replacement therapy and you're like, no, I don't want to do that, then, I'm sure most people will be willing to discuss those different options with you and kind of help go through those different options. So, everyone's journey is different. I like to think, and I agree with Andrea, that this is a natural process. So we'd love to go through that journey with you and help get you through that. and then weigh those risks of the different therapy options.
The other thing I wanted to contribute, Jen, as an epidemiologist, and and I have a clinical background too, but when women heard in 2002 about the risks and benefits of estrogen plus progestin, there was a huge decline in taking hormone therapy of any type in the country. Women voted with their feet when this information came out, because we didn't have solid information about diseases until that time. And I wanted the audience to know that after that, the SEER data showed a marked decline in breast cancer diagnoses in this country. I should put the slide in that shows that decrease. And that was the piece of breast cancer that was caused by hormone therapy that was largely taken away by women stopping taking it en masse. So what that means to me is that some 25,000 breast cancer diagnoses a year stopped happening because of the trial findings in WHI and people making more informed decisions.
That's so important. And I feel like my mom was one of those women, and I saw that happen. And I also saw her like really struggle because we didn't have these types of resources, right? And I feel like so many of these comments are coming back to something we discuss on these forums so often, which is like how to be your own advocate, how to know what to ask your doctor, how to come up with what's right for you. That's what wisdom is about, right? It's not every treatment, every screening, everything is going to be right for everyone. How do we each figure out what we need? I see one more question. I did just want to note before we get to that, I know folks are dropping off. Please do the evaluation. There's a link right here. So please fill that out so we know how to make these the best they can be. And then we'll go to Linda and we'll wrap up. Linda.
I just wanted to say about 18 years ago, I went to my OB/GYN and he put me on hormones. I don't know what they were, but one of them I took for 2 weeks and then I added another one. I did it for 2 months, but I had the most severe depression from those hormones than I'd ever had. So I quit, and now I have an OB/GYN, but I don't go to her. As a rule, I have a general practitioner that does, and I'm also 66, so I learned I don't have to have pap smears after 65. Something good about being a senior. So, but anyway, now I lost my train of thought. But I was going to add, my general practitioner, I like having an OB/GYN because I did have a lump, it was benign, but my general practitioner doesn't have the knowledge and experience with breast that my OB/GYN does, I feel. So, but anyway, but it was interesting because I couldn't stay on those hormones. I wouldn't be here today, I think, so anyway.
And
I'm
Linda,
so glad you were able to stop.
The data showed that when we thought everyone should take hormone therapy because we thought it was so widely beneficial, that lots of women started and half of them discontinued because they didn't like it within a very short time. So you're not alone in not liking that experience.
Yeah, I mean, it frightens me to think about it even still. And I do know a few women that are on antidepressants because they can't take any kind of hormones because of their family history and things too. So.
And there was a question about the type of breast cancers that were prevented when women stop taking hormone therapy. I think it's predominantly estrogen receptor positive tumors.
It is, but it's not just, but there was a fraction of those that were node positive, and it's not like it was, we were looking, there are some very benign low risk cancers. It's not like all DCIS and like stage 1A cancers. It's not, some of them are, at least 25% of them were stage 2 and 2B and things that, had lethal potential. So it's, if you can avoid taking progesterone, it's a good thing. Or if you take it, try and take it for a year or two and not take it for long periods of time. I mean, everything, as I said, is a negotiation and a trade-off, but yet another reason to know your risk.
Know your risk and take good care of yourselves like we know you will. So
choices.
The importance of these big trials, right? That Women's Health Initiative, huge landmark trial for improving women's health. So it's so important for us all to come together and learn together and advocate for ourselves and each other and our mothers and daughters, right? So I think, there's a few slides, just, if you want to follow Wisdom, know what we're doing. If you haven't joined the Wisdom trial, please reach out. We can answer any questions folks have about the study. Our next session, speaking of, is going to be sort of breast cancer 101 and a resource guide. We want to talk about how to advocate, how to have conversations with your doctor, what you need to know as you're thinking about breast cancer, your risk and opportunities to reduce your risk. So you all are here, you should be signed up, but spread the word. And then we have a few events coming up, especially for folks who are local. Some of these are local to San Francisco, some will be virtual if you want to join and learn more about breast cancer in Breast Cancer Awareness Month, which starts next week. Somehow it's almost October already. So we will be sending out information on these on sort of the various social media platforms if you follow Wisdom anywhere. So any other
Thank you
announcements,
everyone for being
Allison?
with us today, and
Yeah.
share with your friends. Talk about menopause. Don't
Talk
keep
about
it a secret.
menopause. That's exactly it. Thanks everyone so much.
Thank you. Thank you.
See
Great.
you
Thank you,
soon.
Tessia. Thank you, Andrea. And thank you, Jen, for great moderating. Thanks all for
Absolutely.
Thank you
joining.
all so much for being here. We appreciate it.
Bye.